You're in this field because you care. So if you're losing that, if you're getting apathetic, if you're getting cynical, that's a pretty good sign.
Interesting.
If you're getting stuck in dread, waking up with anxiety, resentment, right? If you're being stuck in that emotional space, so those are some signs at work. This also impacts your relationships. This is actually one of the areas that you start to see signs. Being short and reactive to your spouse, to your kids, being impatient. It can also be with your coworkers, with your team. It could also look the opposite, becoming more distant, withdrawing, not engaging with others as much, having more conflict. And then I think one of the biggest ones is health, right? Outside of public health, what we know is about 50% of all adult healthcare visits, like to primary care, can be traced back to something stress-related. Burnout accounts for 125 to 190 billion dollars. Hey everyone, I'm Marissa McCool, the Public Health Burnout Coach, and you're listening to the Public Health Insight Podcast.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. Now we want to spend some time unpacking what it means to public health specifically, why it exists, and whose responsibility is it to address burnout? Because I know you have some very kind of strong ideas about what that looks like, and I think it's important for our audience to understand that. So I want to start off with this whole idea of, so you talked about selling public health is something that we're not as equipped to do, and something that we don't do as effectively as communicating the basics of, like, this is evidence-based, so you should do it, but we're not able to sell it to someone who maybe isn't from that world. So public health is a very broad field in terms of there's so many different professions. There's job titles being made up every day. Some people are in public health without knowing they're actually in public health, right? So given all this complexity, before we get into public health burnout, who is a public health professional in the first place?
Yeah, I think about this all the time, especially when it comes to like my marketing, right? How do I reach the people I want to talk to? Like I have friends who work in burnout with lawyers. I'm like, that's so much easier. Lawyers, right? Everyone knows if they're a lawyer or not. So I think about public health kind of as a Venn diagram, right? So on one circle are what we may call the preventionists, people who are doing work that could fall in prevention, researchers, even program implementation, right? Where the whole purpose is about prevention. Then the other circle is kind of treatment or direct service. So this could be doctors, this could be social workers, this could even be teachers, right? I think most often we think about the medical field. And then there's a place where they overlap, right, in the middle. So the folks that I think about and that I work with are kind of in the part of the preventionists that aren't directly overlapping. Now, of course, they might collaborate with those stakeholders. Their research might impact that, but they are the folks who are kind of at the state and local health departments, at their federal agencies, sometimes in academia doing public health research, sometimes nonprofit. That's kind of what I think about when I think about public health. But it, of course, doesn't exist in a vacuum, and so much of our work is collaborating with others. And there are people doing public health work, as you said, who don't really know that that's what they're doing.
Mm-hmm. Yeah. Okay. So that's a good... I like the preventionist direct service framing. So I'm going to use that going forward if I get permission from you. Yeah. Now, burnout, as you said, you mentioned your experience in 2017, experiencing something and then being able to name it as burnout. Now, can you talk through, and burnout as a term is more popular than it's ever been because obviously there was that pandemic that happened that kind
little
of
thing called COVID,
catalyzed, a lot of people might have been experiencing similar things already, and that's something that kind of pushed things over the edge a bit in various ways. When we look at and burnout, I imagine affects many different industries and sectors. Where does public health fit specifically in that burnout, given the unique pressures a public health professional might face? Like, where does public health stack up to other industries, or if you could talk about some statistics and importance of burnout?
So it's very similar, and I'm going to talk in the context of other helping professions.
Right. That's a good way to think about it.
So, I will say burnout in public health, the research is lacking, although since COVID, there's more and more research on it. And we do need to name most people were burnt out before COVID, right? But it's just got the spotlight. One of the best sources is the Public Health Win Survey, which is currently being collected, but the last data we have from 2020, and I should say they collect data from health department staff, missing some population, but 1 in 3 individuals reported considering leaving, and 41% said because of burnout. Now, 37% said because of stress. So there is a little, how do you interpret that? Because stress and burnout, are very similar and whatnot. But compared to kind of other fields, the American Medical Association finds on average physicians have about a 50% burnout rate. I think last year was 48%. 1 year it was 63. I think that was in 2021. So the pandemic's still going really strong. Social workers fall between 40 and 50% burnout. Nurses are similar, right? So public health kind of falls in a similar range. But there is the caveat that we don't have the best data on it. One of the more interesting recent studies from, I think it was Middle State Tennessee University, did a little bit more deep dive. And they found that burnout increases the longer you're in public health. So they use, one of the stats they found was folks who worked in the field for 5 to 9 years had a 90% higher self-reported rate of burnout than people who were in their first year in the field. They also found that the highest rates of burnout were for folks who were already 15 years in the field. And then they also found that folks in public health academia had the highest rates of burnout compared to some other fields. So we're getting some more data and understanding the nuances of it. A lot of this I've seen reflected working with women in public health too. Definitely, the longer you're in the field, not only are you kind of losing that doughy-eyed, big dreaming grad school self, but you're facing challenges that grad school never taught you how to face. Then you're trying to build a personal life, maybe get married, maybe buy a house, maybe have kids, then you're a parent, then you're maybe raising your kids while taking care of your aging parents, right? So the other challenges also contribute. And then you might be moving up in a leadership role with more challenges that you might face. So it makes sense, kind of what we're seeing as the research develops.
I like where we're at now because I think we can get into the nitty gritty. So now, there's more visibility on burnout. There's more conversations about why it's important to be aware of it, why it's important to address it. How do we kind of engage in dialogue with people who might disagree and say, hey, everybody experiences burnout. It kind of is what it is. The statistics and what we're learning through research isn't necessarily looking very, very promising. I mean, there's things that we can do and hopefully we can reverse that. But is this a trend that we can just say will persist forever? I guess the other angle too is the goal to get to a level where there's no burnout at all? Because someone might say, well, there's nothing we could do to fix it either. So should we not just leave it alone and do nothing? I can anticipate what you're going to say, but I think it's important for us to kind of talk this one out because
this comes up a lot.
Right. That's a lot.
Right.
Of what
a lot
I
of
hear.
people think this is just the way it is, but think about it this way. If I said to you or anyone listening, drunk driving is the way it is, there's nothing we can do about it. Right. School shootings is just the way it is. There's nothing we can do about it. Right. We would never agree to that ever. Fair. Right. We'd say, here's a negative health outcome. Here's an inequity. Here's a negative experience that we can prevent, that we can address. But we don't think about that when it comes to burnout within our workforce, right? Even think about stress. We know from our research that stress causes health issues. And we are putting money into addressing the stressors of environmental impacts, right, of violence, so that stress doesn't impact the communities we serve because we know it affects their health. Why don't we give ourselves that opportunity? Why don't we believe that's possible for us? And I think that is a huge problem in public health. We are so focused externally that we don't see ourselves as a population that needs serving. I mean, yeah,
Mic
it's
drop.
just true.
That's so true. I even get that vibe with even people being fairly compensated too.
Yes.
Because it's like, no, you're in social services. How dare you take money from programs that could benefit the community? You should just be happy with what you earn and live with that. And I think that's kind of a microcosm of the bigger picture too, about the value we place on ourselves as in sort of that service profession, and how we see ourselves benefiting from interventions themselves. Because some, like you said, there might be interventions for the workforce itself, but there's something in terms of resistance to accepting that, or systemically not believing that's a worthwhile investment to kind of address.
Yeah.
Right?
And I even see this where even when I was at UC Berkeley, they have some of the best researchers looking at paid parental leave. Mm-hmm. But UC Berkeley did not offer, at least at the time I was there, great parental leave.
Right.
And so this is something that, we have to address, is understanding how the public health workforce has developed. It has developed and been built and operates under white supremacy, the patriarchy, and hustle culture. Right? So when you start viewing it that way, you start to see why we've been kind of trapped in this place where we don't get a lot of funding. We don't have great pay. We have this belief you have to be a martyr to the cause and sacrifice yourself to sacrifice others. Right? Because who benefits when the people who want to help the world get better, the people who want to dismantle systems of oppression in communities, are burnt out and who are underpaid? Systems of oppression. Because then we don't do as good of work, we don't have as big of an impact, and then those systems continue to, have their negative, harmful effects. So when you view it that way, you kind of see how the current structure in public health workforce is actually an outcome of those systems of oppression, and in many ways is kind of still replicating systems of oppression internally and externally. Think about
cutting funding, resource limitations, and perpetuates not solving the problem, burning out people even more. Right. You kind of don't really get anywhere.
Yeah. And think about who works in public health, right? It's largely 70% women, right? Or people of marginalized identities who have been directly impacted in their community, and that's why they're doing this work. And then they're kind of facing discrimination, pay gaps, right? High burnout rates, versus some other fields that maybe have a different makeup and aren't kind of operating as much under these systems of oppression per se, right? You gotta start kind of thinking about the history. Once you start looking at the history of how public health developed, the Industrial Revolution, you start to see how where we're at now is tied to that. We got to start changing some of that, rather than just be like, oh, nothing we can do.
Right.
This is just what service individuals do. We just sacrifice everything. Why do we want to live in a world where the people who are doing the most helpful, powerful work are the most ill-treated, are the most poorly paid? No, I want to live in a world where the people who are helping others, who are changing the world for the better, have a great life, are paid really well, right? Are respected.
That makes sense.
Right.
I think so. Yeah. Now, some people might be like, oh, okay, I don't experience burnout because I don't have an uncontrollable reaction to something small that I haven't kind of reacted in that specific way before. What other symptoms or signs of burnout that are maybe more common that people experience that they're not even aware that it could be a symptom of burnout?
Yeah. So I always like to remind folks that burnout is a spectrum. It does look different for everyone in different seasons of your life. I'll have a lot of people come to consult for my program and say, I'm not burnout. It's not 2020. I'm not doing Zoom school with my kids. I'm not like doing COVID tracing. And I have to remind them burnout's a spectrum. And it's really hard when you work in a field where everyone's stressed out, right? It's like, how do you tell a fish it swims in water? That's kind of what it's like. So there's a number of things you can look for. And as I say then, I think a lot of us will go, that's just the nature of working in public health. Right. No, it's not. It's not normal, right? We are not born to have these experiences. So here's some examples across work, relationship, and health. I'm just looking at my notes so I don't forget anything. Right? At work, a loss in fulfillment, a loss in passion. This is really important because people get into public health because of their passion. No one comes into public health for any other reason than they care. Typically. There's some rare folks, right? But for the most part, you're in this field because you care. So if you're losing that, if you're getting apathetic, if you're getting cynical, that's a pretty good sign.
Interesting.
If you're getting stuck in dread, waking up with anxiety, resentment, right? If you're being stuck in that emotional space, so those are some signs at work. This also impacts your relationships. This is actually one of the areas you start to see signs. being short and reactive to your spouse, to your kids, being impatient. It can also be with your coworkers, with your team. It could also look the opposite, becoming more distant, withdrawing, not engaging with others as much, having more conflict. And then I think one of the biggest ones is health, right? Outside of public health, what we know is about 50% of all adult healthcare visits, like to primary care, can be traced back to something stress related. Burnout accounts for $125 to $190 billion, according to Josh Go. He's an economist, which equals about 8% of the national U.S. healthcare spending, right? So stress and burnout have a huge health impact. So this can look like, for me, my psoriasis was flaring when I was burnt out. For someone else, it might be eczema. It might be hair loss, trouble sleeping, gaining weight, increased blood pressure. And then there can be some other things. So like maybe diabetes. That might not directly be from stress, but if you're stressed and you're not exercising, you're not eating well, right? That can lead to diabetes. So there's a whole host of things. And in my program, we have an assessment that folks do so they can see where they fall on the spectrum. Because if you don't name where you're at, you're going to have such a hard time solving your problem and getting out of it, right? Just like in public health. Before we implement a program, before we implement a policy or intervention, we have to do some research to understand what is the problem we're solving. Same thing individually with our burnout and our stress.
Now, one interesting thing I've heard you talk about on a few different occasions, you have your podcasts or the other mediums that you're active in, is you do name and call out sort of, as you eloquently described, the systemic issues with kind of, I think, burnout and hustle culture, I think is a term I hear you use a lot. And that contributes to how people maybe behave in a workplace and internalize different things. But you also, on the other hand, you empower people to take some individual level of responsibility as well to address the things that they can. And I think you kind of frame it as there's a lot more you could do about it than you actually think. And I think that's something people will have a hard time. So how can I? Everybody works hard. My boss wants me to do this. My boss wants me to do that. So can you kind of unpack that a little bit? Do you feel like in this case, or even public health in general, it gets a bit too deterministic, like everything's outside of your control and you're kind of a victim to the circumstance and there's not much you can do? And it's almost like that's another layer of oppression added on top of. So it's a complex concept here. So let's unpack that a little bit.
It is. But I do think that happens. We get into this place where we think everything's out of our control and that there's nothing we can do. And that's where the apathy comes in, the just deal with it, right? And that is so disempowering. Right. And it's also not true. It's not true. Now, a lot of times people want to go to okay, well, is it the organization's fault, the system's fault, or your fault, right? This either or. It's not that. It's not either or. They both contribute, right? So I like to talk about the kind of causes of burnout from external and internal points of view. There are external causes, like we've been talking about systems of oppression, right? When there's discrimination and bias in a workplace, when there's inequitable pay, those do contribute to stress and burnout. When there is not paid parental leave, right? When there's lack of funding, lack of staff, those do contribute. We are not denying that. However, if we just sit around and wait for those to change, we are going to be waiting forever. We don't have time, right? The goal is that they will change, and many of us are working towards that. But if we're in public health, what do we know? Systems change, norms change, policy change takes time. Takes time to see the impacts and the effects, right? So it's very disempowering to say, oh, just wait for that to change. But it's also not true, because the other part of it that contributes to burnout is what's happening with us, right? This is the internal causes. So this can be tying your worth to your work. A lot of this is subconscious, right? But for many of us, we have created public health as our whole kind of identity because we're in the field, because we care about it, our passion. So I saw this in the pandemic a lot. A lot of people didn't take their public health hat off outside of work. And they were educating their friends and getting upset by what their friends were doing and on social media and commenting, right? Right there, that attachment, that identity to your work being so deeply rooted is driving you to overwork, to take on too much responsibility, right? And to not rest and have some peace. The same thing comes up from when you have internalized perfectionism. So you're unable to just send out an email with typos or submit a report where it's not perfect. So you're overworking, trying to constantly fix. And then you're criticizing yourself on the back end, right? I talk about this a lot where even when you're not at work, a lot of folks in public health are mentally at work, right? They're at home thinking about the mistakes they made, replaying something that happened, worrying about tomorrow, thinking about tomorrow, right? You're not getting mental rest. So we have this internalized belief that we have to earn our rest. It has to be given to us, has to be justified. So this is how it looked for me and many people I work with. It'd be lunchtime, my stomach's grumbling, and I'm like, no, I have to finish this report. Like, I'll just finish this report real quick. Then 2 hours later, I haven't eaten my lunch. Right? So I'm preventing myself from taking the break my mind and body needs.
Because you want to finish and get that as a reward. Okay.
Exactly. So there are some things we can do for ourselves. Like when we are not saying no because maybe we have some internalized doubt, right? Or shame or guilt. Or again, going back to internalized depression, if you've been told your whole life you have to work twice as hard to get half as far, which we're not denying, there are external inequities that comes from. We're not denying that. But when you believe that, what happens? You don't give yourself rest. You don't say no. You overcommit, right? And then when you're overcommitted, you're overworking. And then your work's not as good quality. Then you make more mistakes. Then you have to work more. Then you feel worse, right? So there are things you can do individually to get more rest and reduce your stress right now. But it's a big pill to swallow to say, hey, I have some responsibility here. And here's the example I really like to use. Again, back to public health. How long would you say we've been doing, public health prevention around smoking cigarettes?
Oh, decades.
Decades, right?
Decades.
12% of the American population still smokes cigarettes, right? Now that's low compared to decades ago, but it's not zero. Even though you can't smoke on planes anymore, you can't smoke in buildings. A lot of buildings you can't even smoke outside them. There's warning labels, so much education. Why do those 12% of people still smoke? Even though they know it's bad for them, even though some of them have the negative health consequences. Because there is an internal reason keeping them smoking that hasn't been addressed, right? And I see this with my mom, lifetime smoker. Like, let me tell you, at my MPH graduation, I was like, Mom, give me one gift and don't smoke here. Oh. Like, come on, don't embarrass me, right?
Yeah.
But like thinking about that, why does someone still smoke cigarettes? Because they don't know how to manage their own emotions. When their shame comes up, when their anger comes up, when their anxiety comes up, they don't know how to process that. They don't know how to manage that. They smoke a cigarette and it does the management for them. Right? So even though they know it's bad. Similar to a lot of things, yeah. Right. Even though they know it's bad, even though there's all these policies in place to stop them from doing it, the internal cause of it hasn't been addressed. So therefore they're continuing to do it. Same thing with burnout. Like tomorrow, if overnight all the external challenges change.
Wow. Okay. I see where you're going.
You still have to address it. And we see this in companies that have switched to unlimited PTO. I don't know if you've heard this.
Yes.
Staff take less vacation time, even though the policy gives them more. Right? I theorize it's because the internal hustle culture, burnout badge of honor, thinking that they're going to look lazy, stops them from actually taking advantage of that policy. So it's not either or, it is both. However, right, if we want to experience like more immediate changes, the individual level is where we'll get the most bang for our buck right now as we continue to work on the community level. Now, here's the other thing to think about. What creates norms? What creates policies? What creates structures? Individual people who come together, right? A norm is just the outcome of a majority of people acting the same way, having the same beliefs. So the more individuals that detach from hustle culture, that prioritize rest, the more the norms are actually going to change.
Right. You can't, you could shift norms top down, kind of, but you can also shift them bottom up, so to speak, which is what you're going for. Right.
Yeah. So we do have to address both. But I work with folks on the individual level because that's where we can see the most immediate impact. And people who are burnt out, your health is impacted, your relationships, your time with your kids, the quality of work, your happiness. We don't have time to wait. We really don't.
I like that example that you gave. I've never heard it framed like that before. Like in theory, if we were to remove all the external factors through policy or a snap of a one now, would you expect everything to change? And you're saying, even if that happens in the case of hustle culture, a lot of it would change, but there's still some prevailing individual level beliefs that are internalized that wouldn't change. And you gave some really good examples of when the system does change, that you don't see a proportional change in behavior as a result because of those held on strongly beliefs. So it's a multi-pronged approach, as they say in public health, right? And you're talking a lot about the individual level. Now, one of the things I've seen you say is it is possible to eliminate a lot of the work stress and I think you said double your free time. So I'm reading that. My head is exploding as I'm reading that. What do you say to people that say, Marissa, this sounds good, and I think I can make a little bit of a change, but it probably won't lead to as big of an impact as you're saying? It's too good to be true. Like, what would you say to people who come back with that?
Yeah, that's very common, which is what I've started doing in my program, is kind of taking the assessments we do and sharing some of the data. Because I will tell you, public health folks, I think, are some of the most skeptical folks out there, because we're so into research, right? I get it. Me too, right? But in my program alone, in 3 months, what we find is women stop overworking nights and weekends by 50%. They get 40% more rest, right? They get 25% more time to prioritize their health. Some of them in my program go from working out 0 to 3 to 4 times a week. One woman had a Garmin watch. They track your sleep. Mm-hmm. It goes from a 0 to 100, 0 being terrible, 100 being excellent. She went from about a 0-1 to a 90. Right? So I'm seeing these real-time results. So I know it's possible, but I get that other people don't see it. And last week I did a whole week-long challenge explaining to folks how this works. And you really have to understand neuroscience and the science of rest and how our brain works. So just to give you an idea, right? Our brains are not machines, right? They are designed to get rest, right? If you are working past your brain's capacity, it processes the information slower, it makes more mistakes, it doesn't problem solve as quickly, right? And so what happens when you're overworking is your brain is not working at its highest capacity. So you do drop the ball, you do forget things, right? You do make mistakes. And then what do you have to do? You have to redo all that stuff and fix all that stuff. So it adds to your workload. But what I have found with women in my program is, like, when we do prioritize rest, when we do start taking breaks, your brain functions at a much higher level. So you're making less mistakes. You're thinking quicker, right? You're making better decisions. And so then you get work done faster. It's more efficient. And you actually do get more free time because of it. And since the pandemic, more workplace studies are showing this, right? There's been some studies that you work for 50 minutes, take 10 minutes off, it increases your productivity by 13%. There was a really fascinating study in Sweden in a surgical department, right? We think about doctors and nurses having to work 12 hours a day. They had the nurses work a max of 6 hours a day, no more than 30 hours a week. They found their efficiency went up by 20%. Their surgery wait times went from months long to a few weeks long. Why? Because when our brain is rested, when it has the recovery, it is more effective and more efficient. This is why I say systems of oppression want people in public health to burn out, because we're less effective. Our work isn't as high quality. We don't have as big of an impact, which is exactly what hustle culture, white supremacy, and patriarchy wants. And so because we're so in it.
Outcome as a measure versus the input, because input is like, how many hours did you clock in and work today? And then the outcome is like, what is the wait list for surgery, and the different types of positive outcomes that come from how a surgical unit might perform versus like nitpicking over like you should work more. Yes.
And I asked this to my leaders, okay? Would you rather your team work 50 hours and get, 70% of their work done at low quality, or work 30 hours and get everything done at high quality?
Every that question will make people's heads explode.
Every leader says the latter.
Yeah.
But why doesn't our workplace operate that way?
Exactly.
And I won't get into too much of the details, but when you study the Industrialized Revolution, the period in which the economic center went from individual farmers out on their own land, tradesmen, blacksmiths, right, glass blowers to factory centers, where then it shifted from being paid for your trade, for the outcome of your product, to being paid for your time, where the machines made the product and then the human was just the time, and then the inequity of who's on top. There was an equity before that, right? Of course, but this has a big impact on how we see our work now. This is a big impact on why we tie hours to money, right? This has a big impact to why we think you have to work more to be more productive, to get more successful, because that's kind of the messaging we got in the industrialized revolution. So once you start to understand history, you start to understand a bit of like where we are now and why we're here.
So public health broad, lots of different people fit into that category of public health worker. In terms of the help, maybe I'll say help seeking behaviors, obviously there's gender differences there, but also do you see any differences, even if you could speak to your clientele specifically or what you know, in terms of the roles? Like, are you more likely to seek help if you're in leadership versus frontline? Do you see any does that shake out differently? Is there any trends that emerge there?
So like seeking to get out of burnout, like getting
are you more likely to try to address burnout if you're in X role, or if you're X gender, or if you're...
What I have found, which is very fascinating, the people who are most likely to seek out help for stress and burnout are the new grads, right? Okay. The people who are coming out of grad school and getting into the field. Now, they're not the most burnt out. They're probably the least burnt out. But I think the reason they're the most likely to seek it out is because they're new, right? They're seeing the problems. They're not numb to it, right? It's kind of like, when you walk in your house and you put your coffee cup down, the next couple of times you walk past, you're like, oh, I need to move that. I need to wash that. After a while, you barely even notice it, right? Your brain doesn't recognize it. And then your partner weeks later is like, why is this still here? You're like, oh, I forgot. Same thing when you work in the field for a long time. So the folks who are newer to the field, they see the issues, they see what's starting to happen, and they don't want it to happen. The folks who have been longer, again, it's just like they've been around it, they've become apathetic, they don't see any models of change, they don't see any inspirations, they don't get told it can be different. So they kind of just get to this place of complacency, and then it can be even harder to reach out and get help because you don't believe it's possible to change. And so much of the work I do in my marketing, in my education, is just showing people it's possible, helping them believe it's possible, because it is. I know it is. But so many people in public health don't have that belief because, no one's telling them, no one's showing them.
No, as the public health burnout coach, can you talk about the services that you offer and what people can look forward to by partnering with you to kind of work through a lot of these burnout challenges that they want to prevent, or they are in the middle of and they need some guidance around how to navigate that? What can people look forward to by kind of connecting with you and using those services?
Yeah. So I work mainly with mid-career women. So although a lot of folks who are maybe most eager are younger professionals, I don't generally work with younger professionals. Right. I work with the mid-career women, 30 to 55, who are really in burnout. And I work with them for about 6 months, week to week. They get evidence-based tools and strategies. Basically, what I've done is I've taken all my research, all my knowledge, all the tools I've tried, and I've tailored them to public health, and particularly to the experience of a woman in public health, so how it can apply to them. And they get accountability, they get check-ins. I help them overcome their barriers, the challenges that come up in their context, because we're not denying the challenge of a single divorced mom is going to be different than a childless married person, right? So we address those individual challenges, but the goal is they learn the skills and tools to process their emotions so they don't get stuck in resentment and frustration and anxiety, to undo their internalized sexism, ableism, hustle culture, so that they can say no confidently, so they can stop overworking, to set boundaries, right, without burning bridges, to be able to delegate in a way that helps their team, doesn't harm their team, right, and to create this work-life balance. They build all the skills that honestly I think everyone should learn in grad school. And I'm actually in talks with a graduate program to come do regular yearly trainings for their students so that they get these skills coming into the field rather than down the road.
Yeah, down the road.
And then women who finish my program have access to alumni resources. We give continuing support, after all that. There are some organizations that I've started working with more, doing webinars and workshops and consulting.
Right.
The vast majority of my work is individual.
Right, one-on-one.
I love that organizations are interested in it, and I love supporting them. But what I have found is they only want to address the external piece. They do not want to invest giving their staff internal level resources, right? Whether it's coaching, whether it's support, right? There is still that resistance to that kind of individual level support being provided by the organization. So
that's interesting. That's contradictory to my experience. Is that the critique of that I hear from staff in organizations is that there's too much focus on training us to be more resilient, whatever, versus so it's interesting that you're talking about like a flip where.
Okay, so let me clarify here.
Okay.
That resiliency training is not individual level support.
Okay, so you're talking about individual, like actual support, individual level
learning
support.
Tools, having support, like to actually implement concrete evidence-based tools. A resiliency training is not that.
Okay.
It is not that. It's kind of like, I think that this isn't a direct comparison, but this is the way I like to think about it, right? Doing a kind of anti-racism training is not the same as teaching someone how to undo their internalized racism.
Gotcha. It's very different.
It's very different. How do you do that in the day-to-day? How do you check your biases? How do you change your beliefs? It's different than a one-time training of the impacts of it.
Gotcha.
Right? So I think more and more is going to shift, but there's still the challenges of the funding, the prioritization, the politics of it. Yeah.
Any final words?
Any final words?
Anything.
I'm like, what did we not cover that I think is really important? I think probably what is the most important thing for folks listening is if you found your brain being resistant to this, like, but it'll never work in my organization, in my situation. Yeah. That's okay, right? That's what I was like too. I was like, you're kidding me, right? It's my leadership's fault. They're giving lip service. They don't care. They don't understand. Like, trust me, I was like the hardest person to coach when I first started learning this stuff. But I will say, if you use that resistance to keep you learning, to keep you exploring, because that's what I did. I was like, I don't believe this, but I'm going to do what I can to figure it out, to prove you wrong or to prove myself wrong, right? And if you do that, then that actually gives you more opportunity. The worst thing is to just shut down and be like, nope, no, thank you, right? It's kind of like confirmation bias. Why do climate deniers continue to not believe climate change is real even when you show them evidence? Because of their confirmation bias. So do not let your confirmation bias stop you from at least giving yourself the opportunity to continue to learn and understand and explore. And then ultimately, you always get to decide what you want to believe is possible, what is available, but give yourself the opportunity to really like understand and do the research and learn about it before you shut down. Right? So just be aware of your confirmation bias, because what systems of oppression want is for you to just believe nothing's possible. You have to be stuck, burnt out, and unhappy in doing the work in the world that could be 10 times more effective. Just think about that.
I like that. So my takeaway in as few words as possible is don't suck it up. Don't suck it up.
Don't. That's not heroic behavior.
Fair enough.
It's not.
This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art design for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.